Subscribe to our YouTube channel and press the bell icon to get the latest updates.
Hi everyone. India's COVID numbers are finally coming down, and we still have a lot of lingering questions though about vaccination rates, oxygen demand, and most ominously, something that's on everybody's minds right now is the third wave. And the questions are there because the daily numbers have come down, but they're still not small. So, where are we headed? Is there a third wave coming? All of those questions are there, and to answer them, I have with me today Professor Bhramar Mukherjee, who is the chair of Biostatistics, a professor of epidemiology, professor of global public health, School of Public Health in the University of Michigan. Welcome, Professor Mukherjee. Thank you so much. I also have to mention here that Professor Mukherjee is an alumnus of my college, Presidency College, Calcutta, so that also makes her a very special guest. Tell me how...
Abantika, I'm also very proud of you as a Presi alum. And I think that we need strong female voices in academia and media, and you were one of them. So thank you for that.
Thank you so much. So tell me, how do you read the India numbers? Is there any way of knowing how much we are underreporting, overreporting, whatever we are? And also, very importantly, how are we doing vis-a-vis other countries? You know, is our extent of underreporting, because I suppose that's what it is that like at par with the global numbers?
So thank you for that question. And I think that it is nearly impossible to capture all COVID infections and deaths. And this is true for any country in the world because there are some intrinsic features with getting tested. And so there are many asymptomatic infections that you'll never be able to capture. But then there are other buckets of underreporting where people do not have access to testing, right? So that's acute in low and middle income countries. And it was true to some extent in the initial phase in the United States as well. But then it became much more readily available. And right now in Michigan, you can get tested very easily. There are places to get tested for free everywhere in every pharmacy. So it has become much more accessible. But then there is this bucket of people not wanting to get tested because of stigma, because they don't want COVID and they want to power through at home. So there is this third bucket. And then there is also there is data suppression to maintain public image. And we see this throughout the world as well. For deaths, I think it's a different issue. Some of the deaths are because people did not get tested and it's happening. Some of the deaths are happening post-COVID when the patient probably has already tested negative, but it's a direct consequence of COVID. And kidney disease or heart disease is being attributed as the cause of death. And then the third thing is, again, people not wanting COVID on the death certificate because of various reasons. And in India, I think the problem with death is really severe because many deaths go underreported even under normal circumstances. Deaths happening outside hospitals in rural areas, the civil registration system captures only a fraction of the deaths. So now with COVID, I think the problem has become much more acute that compounded with the stress on the system. And that's why you see these backlogs being updated. But also, you know, it's very hard to decouple what causes which underreporting and how much of it's conscious and how much of it's a systemic flaw. But definitely, I think that the death reporting system in India needs a major overhaul in general. And it's really compounded and becoming more acute due to COVID. And our estimates say that in India, the underreporting factor, and I know there has been a lot of discussion about this, and estimates have ranged from 5 to 50. So our underreporting factor for India is around 6 on May 15th. That means that on May 15th, India was reporting about 270,000 deaths, but the total number of deaths already by the time we estimate to be around 1.25 million. So this is sort of the magnitude. And of course, now we are standing at around 400,000 deaths. And you can see that the true estimates will be somewhere around 2 to 2.2 million if you follow that sort of factor. And we have seen that consistently. And underreporting of cases, we have seen that 1 out of 15 or 1 out of 20 cases are being reported. So when India is reporting 30 million cases, then truly it's 600 million. So that's the magnitude of the number of underreporting of cases. And the infections, we already knew that we are capturing, even in the first wave, only about 6% of the infections. And that was clear from Sero survey, that was clear from all other evidences. For deaths, I want more data. I want the government to release all-cause mortality data from 2019 onwards. We can do a projection that what would have happened had COVID not taken place. And then with that projection, want to compare the reality to understand the holistic magnitude of COVID.
One of the problems with that is actually we've just had the CRS data from 2019 and medically certified deaths are just 22%. This is pre-COVID. Yeah. So even all-cause mortality wouldn't probably give you the causes rightly in any case.
That is exactly why we have a paper which is coming out in American Journal of Public Health. We really called for a revision of this reporting system, because I think there are systemic issues with death reporting in India, and there should be other approaches which can make India really compete and meet the international standards. For example, there was this talk about National Digital Health ID. If everybody really has a digital health ID, it becomes much easier to connect their death data or any kind of outcome data in a timely way. The second thing I also noticed that in rural areas, I think if there is an incentive to report deaths, and community and religious leaders are telling people that what would happen if you don't report death accurately? What are the incentives? What are the consequences suffered by the families? Why death reporting is important? You need that culture of reporting as well. So I looked at some of the very strange laws in India that if you do not report death within 21 days, you have a little fee. And if you go above 30 days, you get a little more penalty. And those numbers are 2 rupees, 5 rupees, 10 rupees. So I do not know whether like the bureaucracy of paying those 2 rupees, 5 rupees and getting a receipt and reporting death can also become hindrance. What does 2 rupees mean? So I think overall thinking about what can really incentivize and encourage improved system for death recording is definitely needed. But your question about 22% of deaths are reported. But I think even with that, yeah. And also, and it's 2019. And so it becomes very hard to project. And this year, I think that there are alternative sources of tapping onto this data. That's why we said that crowdsourcing is also important. For example, if you have inactive Aadhaar cards, for example, in metro areas, life insurance claims. So there are alternate sources of really complementing the registry data with other sources of data. And maybe there is a self-reporting incentive in terms of COVID deaths that you can really call for. So there are several alternate sources of data you can do, and multi-platform linkage can become very powerful. But this digital health ID, I thought that was also a good way of connecting data from different sources.
So before I go on to my other COVID questions, tell me, why is it that the digital health ID would give you a better source of information than Aadhaar? Because we already have Aadhaar, the coverage is fairly good. How is it going to be different from Aadhaar and help us do these linkages better?
Yeah, so I think that the National Digital Health ID, as much as I know, was actually everybody seeking healthcare will have a digital ID. And so it would be much easier to get the cause of death, I feel, if you have access to the electronic health records. So what happens with Aadhaar, probably many of the deaths are registered, but not medically certified. But I do not know that still India's death data comes from the civil registration system. I do not know how it is linked to Aadhaar. If it's actually, so there is a linkage issue which you can actually establish, I think it will be much more improved. It will take a few years, but it will get there.
Mm-hmm. So actually, when you mentioned the 600 million cases in around 15th May, you are actually giving the same number that the government of India is estimating in terms of infection, spread of infection, because around the same time, they had given an infection fatality rate of 0.05%. And that approximately came to the same number.
So let me just clarify that why I do not believe that infection fatality rate number. So this is actually the dangerous part, that think about fatality rate. In the numerator, there are cases, and in the numerator, there are deaths, and then in the denominator, there are cases. So if you are inflating the denominator by saying this is the true number of infections, but not thinking that how can I believe that I have a ratio where I'm mismeasuring the denominator to a great extent, but numerator is intact. So you're inflating, so you are not taking uncertainty in the numerator, in the number of deaths into account. You are only taking the uncertainty in number of cases or infections into account. That's not done. That's exactly why we take underreporting in both the numerator and the denominator into account. And that's where we get that by May 15th, we estimated nearly 500. Now it has come to 600. So it's 1 month, more than 1 month has passed by. So in May 15th, we estimated 492 million infections and 1.2 million deaths, which is sort of a conservative estimate. That gives you an infection fatality rate of 0.24%. That's much more believable because worldwide, the median infection fatality rate has been reported around 0.27% so far. So I think that 0.05% is very unreasonable because of this reason of, I believe that the numerator is intact and precise and the denominator has a lot of uncertainty. That's not done in proper statistics.
Mm-hmm. So it's a bit of opportunistic calculation, you would say.
Yeah, I think this is dishonest.
Okay. Now this is one question everybody has currently. If this is the extent of infections currently, infections are coming down, but do you think we will have a third wave at all? And also, whether there's a way your modeling can factor in mutants?
Yeah. So those are great questions. So again, I think I have to really reflect back to the availability of the data and the accuracy of data. So one thing which has been amazing is that as a modeler also, this has been astonishing to me that the absolute numbers I totally don't believe in, right? The case counts, but the relative trends you can still pick up. And that is exactly why if there is a movement in case counts, we could predict the second wave in the middle of February.
Something like a week-on-week movement or
yeah, so and also it's steady, right? Week on week movement in the case counts. They're very tiny. They're maybe going from 10 to 15 to 20 even in certain districts, but that trend is astonishingly predictive of what is coming. And so maybe the true numbers are 100, 200. But still the relative change you can pick up from your models. And that's why we have been fairly accurate in terms of the timing of the peaks and the duration of the wave and so on, because we could see the trend. So it's like a hill that you can see actually the shape, but the real hill may be much higher, but you can still follow the trajectory. So that's what is happening. It's almost like a shadow over it. And so what we said in the second wave, we could pick this up in the middle of February. And we could pick it up in 3 states, and it was Maharashtra, Chhattisgarh, and Punjab. I still remember tweeting about it because the curve has constantly been on decline for 4 months. And then you see this uptick. For the second wave and the third wave, I think the second wave was, there was lockdowns coming in April in almost every state to some extent. And that suppressed and got the case counts down. But still, there is enough virus in the community and there are new mutations happening. So it's a very dangerous time to reopen fully and let your guards down. I'm really concerned about that vaccination rates are not as high that you can open up without masks or gather and think like the wave is over. And also the sublineages of the Delta variant appearing. This makes me very worried. And in the last 7 days, Abantika, we have seen upticks in Maharashtra, in Kerala, in Andhra Pradesh, and slightly in even Delhi. I am surprised by this, because how could you actually have at least vaccinations, such high percentage of people who already had the disease, right? In April and May, we estimate that to be a large fraction. And then on top of that, we have around 30% with at least one dose in both Kerala and Delhi. And in Maharashtra, it's 20%. But still, we have some protection for some people. Some people have already had the disease, but we are still seeing some upticks. But I think that we did this. So on the other hand, I don't believe that we should prophetically just say that there is a third wave and it's going to kill a lot of people, it's going to kill a lot of children, because there is no data to support it. But in any epidemiologic modeling, if you don't have full control of the virus and you open up, obviously you're expected to see an uptick. So that's where your data nimble policy making comes in, that as soon as I'm seeing it, I'm going to really hunker down and not let it explode. So letting it simmer for a long time is the absolutely wrong strategy for this virus.
Right.
So I do think there has to be more restrictions coming in these states right away.
Just to clarify for my viewers and for myself,
sure.
You are talking about, again, when you say you see an uptick in Delhi, Maharashtra, AP, so you're talking about a week-on-week rate of growth.
Week-on-week rate of growth. So we basically calculate this number R, which is the rate of increase, and then we take a 7-day average over it. And again, Delhi is very minuscule, but Kerala and Maharashtra, you can actually see that the R had dipped down to 0.4, 0.5. Now it's creeping back up to 0.86. It's still not above unity so that you can actually see it. But I actually monitored the trends at a very minuscule way. And so every day. And so I feel like we have to be really on high alert. It's not set in stone that the third wave is going to happen. And I don't think that there is any data to support that children are going to suffer a lot, because all over the world we have seen different scope and different level of the pandemic, but the fatality and the clinical severity in kids are really low so far based on all of the data accumulated. So I don't think that we should create a panic like that. But on the other hand, denial is also not good, that there is a possibility. We have to stay prepared, keep our eyes open, keep our data clues into our systemic policy making, so that we can actually intercept much early, so that it does not blow or explode into a third wave.
Mm-hmm. However, there are two things. The two sets of populations whose lifestyles have been the most affected are kids and elder people. With elder people, we have had some amount of vaccinations. Kids are a completely zero vaccination group.
Of course.
So I think that really increases the risk. I mean, even if we don't want to have doomsday predictions, that makes them a very vulnerable population, because at some point of time, they'll have to get back to their lives.
So I think that there are a couple of things here that why vaccination in the 0 to 18 group is particularly important for India. First of all, if you compare 0 to 18 group in US, it's 24% of the population. For India, that number is 40%. So in US, even with that 0 to 18, most of the 12 to 18 are vaccinated now because we have an approved vaccine. So if you think about herd immunity, with 40% of your population having no vaccines available, it is not going to be possible to reach that, right? So really vaccination in the 12 to 18 and then in the kids is critically important for India. And I have said this in a recent interview, though we believe that the fatality rates are much lower in the 0 to 18 age group, which we have reasonable data to believe, if a large number of people get infected, and we saw that even with a small infection fatality rate or case fatality rate quoted by the government, or in our estimates, 0.2% is not huge. But when you have a surge and when a lot of people actually get sick at the same time, then people die because of the clinical lethality of the virus but also because they cannot get the right care. All these numbers that we are quoting all over the world are under the assumption that people can get to the hospital on time, can get oxygen on time. And if you let things explode, that does not happen. So there is a bump to the fatality rate, which are preventable deaths, not natural clinical property of the virus. And also the virus is getting fitter. We can see that too. So those getting it later and later probably are going to have other severe manifestations we do not know. So that is why I think we have to be really, really cautious. This is really a tantalizingly poised situation for India right now, where we cannot really ignore any kind of data clues and uptakes and really be in denial.
Also, pediatric health infrastructure is way more limited than adult health infrastructure. So that's another
Exactly.
minefield there.
Exactly.
Is there an ideal vaccination rate for a country like India per day?
We have to get to 10 million per day. Otherwise, there is no hope. So I have been saying this all along, that we have to get to 10 million on a consistent basis, right? It's not like one day we have special initiatives and we get to 8 million and we celebrate, and the next day we are plummeting back to 6 million. You have to maintain that 10 million doses. And in weekends, there is not enough vaccine. So I'm taking that into account. So 10 million on weekdays have to be there in order to get to a decent level. And there is, of course, an issue with supply, but I think that manufacturing in India has to scale up. There has to be procurement from other countries. And I'm very excited about the G7 meet and the pledge of the G7 leaders to get 1 billion vaccine. I do not know how much of that India is going to get, but really negotiate internationally and get that supply issue sorted out, because 18% of the world's population live in India. Unless India can control the virus, the world cannot control the virus.
I read somewhere, and I'm very tempted to quote it. This is basically our wits versus the virus's genes. All this mutation that's happening and how fast we can vaccinate, how fast a virus can mutate. That's the kind of thing. Actually, two questions. One is are we sort of caught in a vicious, because we keep hearing about selection pressure that's making the virus mutate, and all the vaccines that we currently have are actually targeting the spike protein. And the spike protein is also where its infectivity is going to go up if it has to mutate. So you're putting all your eggs in the spike protein, and you're making the virus mutate more and more. So is it one of the reasons why it's mutating so fast and becoming infectious, more infectious? Is that a problem?
So obviously, I'm not an expert on this evolutionary biology and the genomic structure of the virus, but what I know from characterizing the epidemiologic properties of the different variants, we just worked with the Imperial College London, Swapnil Mishra. We did a modeling on the Delta strain. And with this is the first time we did a multi-strain compartment model to really quantify how much of the deaths in Maharashtra and the infections in Maharashtra are actually attributable to the Delta variant. And we see that, of course, compared to the original strain, the Alpha variant was around 1.5 times more infectious, and then it has gone up in the Delta variant. And overall, if you're looking at, one thing I want to mention, overall, if you're looking at an R of 2.5 to 3 in the original variant, now you're looking at an R of 5 to 8. So that's highly transmissible, right? And if you think about the herd immunity threshold, it is actually related to this R. So with the R of 3, it was a 67%, right? And now with an R, if you have an R of 8 or even an R of 5, it's going up to 80%, 90%, right? So that's why this is so dangerous, that you also are pushing that threshold of how many people you need to vaccinate, not just like, the vaccines are effective or not. So I think that transmissibility is related to this, how many people you need to vaccinate, and of course, immune escape properties. But thank goodness that even with all of these, new variants emerging, the data tells us that 2 doses of the vaccine or full vaccination offers you reasonable protection from severe disease and deaths. But can we let our guards down thinking about that? Just look at UK, how things have really gradually changed. Initially, yes, infections went up, but the hospitalization did not. But now you see a slight uptick in the hospitalizations as well. And so hopefully we're hoping that we can vaccinate fast enough so that, we do not have that uptick in hospitalization and deaths, that the immune escape properties do not get stronger.
Right.
So that's where the challenge is. And I think that's why the whole world is feeling better. Like in the United States, I see a lot of people gathering and, without masks, and rightfully so, because in the vaccinated group, there is not a reason to worry. But at the same time, I really wonder that where is this, the new variants are circulating in the community, and in the fall, we are also probably going to see an uptick. So for the history of any infectious diseases, I think for the foreseeable future, we really have to be prepared with genomic surveillance, epidemiologic monitoring, our personal prevention strategies to fight the virus. Things are not going to get normal very easily. And I think we have to accept that and navigate our life around that, our science around that, our policies around that.
That was actually my last question. How long does this go on? I mean, how long do you see us balancing all of these things and living with the virus or learning to live with the virus?
It has been really challenging for everybody. And over the last 2 months, just to share a personal snippet, is that my family got really ravaged by COVID, the second wave of COVID. My father, my sister, my nephew, all had to be hospitalized. And the manifestation of diseases from initial phase to next phase was quite different. So I was seeing this science being acted upon. But on the other hand, family members who had 2 doses of the vaccine, even though they had COVID, had only mild symptoms. So that's why I'm putting all of my hope on vaccines and how soon can we get the most of the world vaccinated. That's where our hope lies. But to be honest, even with high level of vaccination, you'll have to be prepared with your personal prevention strategies, as well as, in terms of epidemiologic surveillance, to catch any kind of outbreak. That's very needed. And we, in how many diseases and viruses we have been absolutely able to eliminate from the world. So it's going to stay. And I believe that this is something I have read in many articles that 2022 is still going to be an year of unnerving undulations and unexpected outbreaks. We have to prepare. And then, when the world is getting fully vaccinated, and maybe many of us will need boosted doses over in 2021 and 2022, and depending that we can scale up the supply of boosted doses and vaccine manufacturing, probably looking at 2023. And sorry, I cannot be more optimistic. And it really, for people who have most of their family or 10,000 miles away, not being able to travel when their family needs them or something happens, is just paralyzing, absolutely paralyzing. We're all living with this agony. We're all living with this tension that which way is it going, the pendulum going to swing, and it swings every day. So I say that as a statistician, we are very good at modeling and incorporating uncertainty in our models, but not in our lives. So unfortunately, humanity will still prevail. We'll still try to fight. We'll still try to do science. We'll still try to do as best as we can. But our lives have truly changed, and we have to navigate and and somehow at some deeper level, embrace that.
Basically, stock up on more masks. Masks are here to stay.
Yes, and stock up on more masks, and actually cool masks, so that you have one N95 underneath, but still you can look joyous. So
right.
So I think that you have to find joy in a life, and so we persevere. We try to do the best science, and we try to fight this virus.
Right. Thank you so much, Professor Mukherjee. That was a very interesting conversation. Thank you so much for doing this on a weekend. Thank you. It was great talking to you.
No, it was great talking to you, and all the best to you, and more power to fearless women journalists in India.
Thank you so much, and hope you can travel to India when you're planning to.
Yes, thank you.
Thank you.